Sesi açıyorum. Evet, değerli katılımcılar, hoş geldiniz. Olur mu? Şimdi tamam. Evet, değerli katılımcılar, hoş geldiniz. İzninizle Doktor Rübi'nin de anlayabilmesi için İngilizce olarak devam etmeye çalışacağım. Dear participants, dear students, dear colleagues, good afternoon. Just before the farewell, we will discuss the educational research. Last 3 days, we discussed the changing medical education in organizational, institutional, and instructional level, individual level. And we confirmed that the change is inevitable. We also confirmed that we should transfer the change to the development. We have many problems, many complex problems in medical education. But fortunately, we have robust instrument, robust educational design and methodology to explore, understand, and find solution to these complex problems. Mainly, we rely on the scientific problem-solving process to find the solution that we face in real-life situation. But in this session, we criticize our outcomes of the medical education research. I'd like to ask, to what extent our medical education, finding of our medical education, actually, vast majority of the medical education research produce solution to the problems we face in real life situation. Or there are only just an ornament of our resumes or just a stepping stones of career promotion. What's our responsibility in research process, in educational research projects? If I may revert, how we conduct educational research socially responsibility way. I hope in this session we will have a chance to discuss and rethink this question with Dr. Thomas Reviews. Dr. Thomas Reviews have been working in the educational research methodology and educational technology with respect of the social responsibility throughout his career life. I'm sure many of you is familiar with his study, with his extended research area actually, but I'd like to give a brief information about him. Dr. Thomas Reviews is a professor emeritus of learning, design and technology in the College of Education at the University of Georgia. He was a Fulbright lecturer in Peru and has given invited presentation in the USA and more than 30 other countries. His research interests encompass educational technology in developing countries, design-based research and evaluation. His books include Interactive Learning System Evaluation, A Guide to Authentic E-Learning, and MOOCs and Open Education Around the World, and most importantly, about today's topic, Conducting Educational Design Research with Susan McCann. Please join me in welcoming the Dr. Thomas Reviews. Hello, Dr. Thomas Reviews.
Good afternoon. It's early morning here. Can you hear me okay?
Yes, we are here.
Good.
And
thank
I
you.
know it's very early time in Georgia and hope that we don't disturb your little puppies and your family in early morning.
Thank you. We just took them outside and everything's right. So good.
Thank you.
Yeah, thank you for that generous introduction. And I can't tell you how much I wish I was there with you. I have been very fortunate to visit Turkey at least 7 or 8 times. Most recently was 4 years ago this month in Antalya, which is of course another beautiful city there. Through my work with the World Health Organization in Turkey, I've met wonderful people from all over the world. And for that, I'm eternally grateful. I'm especially thankful for Dr. Umut Kartoglu, who you see pictured here at my home in Athens. We're now living in Rome, Georgia, and we've worked together for many years, and we're continuing to work together. And I believe he introduced me to the organizers of this conference. So Charles Dickens, of course, said it was the best of times, it was the worst of times. I'm generally an optimist, and I like to think it's a good time, the best of times, maybe not the best, despite the pandemic, but I think it's a great time to be a physician, to be a medical practitioner, to be a medical educator, to be a medical student, because so much has been accomplished, and so there's so much value to what you do. Just before the pandemic started, in November of 2019, Time magazine published a special issue on health innovation, and they described some of the amazing achievements in medical science over the last 50 years, a 70% decline in cardiovascular disease over the past 50 years, a drop of more than 1% annually in the cancer death rate, and an increase in the life expectancy for a baby born in the USA rose from 47 years in 1900 to more than 78 years. Sadly, of course, that has gone back a little bit in the wake of the pandemic. Sadly, we're commemorating the 1 million people who have died during the pandemic just here in the US, so many more around the world. You know, within a month after the coronavirus was discovered, medical scientists had sorted, identified, and posted the DNA sequence online. And so Time magazine published another issue in December of 2021, one about a year after the pandemic, and was praising the heroes, the medical and vaccine scientists who developed the mRNA vaccines. It's amazing how quickly that was done. 2 weeks after the DNA was sorted, they were able to key in into machines to create the vaccine. And by December 2020, Moderna and Pfizer BioNTech mRNA vaccines were approved. That's just so fast. I know you all know that. And of course, a major part of this was the use of randomized controlled trials. Sure, lots of other research methods were used, but randomized controlled trials are at the heart of getting a vaccine approved. Now, when you look at education as opposed to medicine, you don't see the kind of progress that you've seen in the last 50 years. In fact, education arguably hasn't changed very much at all, and maybe it's even gone backwards. Whenever Time magazine does a special cover about education, it's usually not good news, like this cover about rotten apples, about how hard it is to get rid of bad teachers. As we look at the innovations introduced into education over the last 50 years, we see that standardized tests and punitive accountability, school choice, these have all utterly failed to improve educational outcomes. In our country here, nearly half of our students qualify for free or reduced price lunches. That is a signifier of poverty. And also large investments in educational technology have not paid off. It's not a good news story, not like the medical science. In fact, 2 new reports that just came out from the World Health Organization about remote learning indicate that remote learning, distance learning, online learning, so forth, really didn't do very well during the pandemic, really didn't serve the needs of students. So much so that many students now are depressed, and this includes medical students, as they've had to force more and more of their learning online. Depression has become, and also dropout. Dropout is enormous. In fact, just this week, the U.S. Secretary of Education, Miguel Cardona, recommended that billions be spent, I'm talking billions with a B, be spent for mental health services for students at all levels in the wake of the pandemic schooling. So, you know, this was a golden opportunity for educational technology to show itself and how powerful it could be, and yet I think it failed for the most part. Now, some people argue that randomized controlled trials, as are used in medical science, are necessary to improve education, that we wouldn't have such high dropout if we would use the scientific method and RCTs in education. For example, the late Robert Slavin, who's the author of one of the most popular educational research textbooks, he says that there are only 5 questions that you need to ask about a research study in education. Is there a control group? Are the control and experimental groups assigned randomly? If it's a match study, are the groups extremely similar? Is the sample size large enough? And are the results statistically significant? Now, not everyone agrees with that. I certainly don't. But another educational research authority, Charles DeForges from the United Kingdom, he says that the status of research deemed educational would have to be judged first in terms of its discipline quality, and secondly, in terms of its impact. Poor discipline is no discipline. I think we can all agree on that. All educational research needs to be rigorous, needs to have discipline. But he went on to say, an excellent research without impact is not educational. Those who argue for RCTs in education, unfortunately, don't acknowledge the huge amount of no significant differences studies that are out there. And so there has been a paradigm war going on ever since I've been in this area. I started in this field almost 50 years ago. And there are really many paradigms, but I'm just going to highlight 4. So there's the positivist paradigm. These are the folks that like the RCTs. These folks believe that there are facts with an objective reality out there that exists regardless of our beliefs. For them, the goal of research is to detect the causes of changes in phenomena through measurement and qualitative analysis. Experimental designs, especially RCTs, are best because they reduce error that hide the truth. So these folks believe there's truth out there and it can be discovered through randomized controlled trials. And the ideal states for these people are like the scientists in the lab. They want to be totally in control and be detached. I'm going to draw out the differences in these paradigms a little bit. Of course, there's a blend, always a blend. The interpretivist paradigm is another popular paradigm. These folks believe that reality is socially constructed through collective definitions of phenomena. And the goal of research then is to interpret phenomena from multiple perspectives. Let's say you suddenly are forced online during the pandemic. What are the perspectives of the medical students? What are the perspectives of the faculty? What are the perspectives of the patients that might be involved in any kind of teaching and learning environment? Ethnographic methods such as observations and interviews are best because they provide the basis for shared interpretations. And the ideal state in the interpretivist paradigm is immersion. When I first started at the University of Georgia back in 1982, I remember one of the students, a doctoral student, said they wanted to do a qualitative dissertation. And her chair at that time, I wasn't her chair, said, "Oh, I guess you don't want to graduate." So there was this bias against qualitative research at that time. Obviously, that's changed quite a bit. Another paradigm is the critical paradigm. These folks believe that reality is individually constructed based upon experience, gender, culture, and other factors. And the goal of research from the critical paradigm is to improve the status of the underprivileged, the disenfranchised. They use things like critical theory to deconstruct phenomena because it reveals the hidden agenda in most educational interventions. And for them, the ideal state is political engagement. Finally, there's my favorite paradigm, which is the design paradigm. And as was mentioned in the introduction, medical education is exceedingly complex. All educational phenomena are exceedingly complex. The goal of research then is to have a positive impact on teaching and learning practice and to contribute to educational theory. It's a twofold goal. So you want to use creative methods, lots of different types of methods. So creative design efforts combined with rigorous evaluation using multiple methods are recommended. And collaboration is the ideal state. You want to be collaborating with researchers, the practitioners, the students, anyone that's a stakeholder in the teaching and learning environment needs to be involved in research within the design paradigm. Now, I think the design paradigm is best for addressing wicked problems. What's a wicked problem? Well, most problems we face are either simple or they can be complicated, but they require time and expertise to solve, but solutions can be found based on experience and expertise. But wicked problems are so complex that normal expertise and experience do not provide ready solutions. They're very difficult and complex. And I would argue medical education is just that. Medical education perhaps has always been a wicked problem, but especially today. I'm sure during the last couple of days of your conference, many of these problems have been discussed. Some that I'm aware of include the fact that students today really need to learn to distinguish between data, information, and knowledge. As a medical practitioner, you're drowned in data and information, but how do you turn that into knowledge, actionable knowledge that you can use in decision-making? Also, it's increasingly important to integrate empathy and compassion with professionalism. And this isn't something that comes naturally to most people, and so it also needs to be part of the learning environment. And finally, more and more medical practitioners are having to learn to work with increasingly powerful machine learning applications, artificial intelligence, side by side with these machine learning. And I give another talk sometimes, it's called The Race Between Human Learning and Machine Learning, and the jury's still out of which one's going to win. So all of these make the medical education today even more of a wicked problem. Another problem is that in medical education, we primarily continue to focus on 3 learning domains: the cognitive, the affective, and the psychomotor. All of these are important, of course, but we've left out a whole domain, and that's the cognitive domain. Now, if you try to type the word cognitive into Word, it'll try to correct it to cognitive. But these 3 domains need to be addressed: the cognitive, the affective, and the cognitive. It's the difference between knowing, feeling, and willing, thought, emotion, and volition, knowing, caring, and doing. And you may think, well, why is that important? I've never heard this word cognitive. Well, it goes all the way back to Aristotle, frankly. And it was a big part of psychology in the late 1800s and early 1900s, but then behavioralism sort of blew it away. We need to pay attention to the cognitive domain, teaching our students not only to know, not only to care, but to do. For example, the CDC, according to the CDC, poor hand washing and other infractions of infection control protocols account for an estimated 1.7 million infections and 99,000 associated deaths each year here in the United States. Imagine that. Numerous studies show that physicians lag far behind nurses in hand washing regimens in hospitals. Now, certainly these physicians have the knowledge and they have the values, they care, and they have the physical psychomotor skills to sanitize their hands, but they often simply fail to do so. They are weak in the cognitive domain. So we need to address this in medical education as well. So I think arguably medical education is a wicked problem, and it perhaps has been exacerbated during the pandemic, when the challenges of providing hands-on experience in real clinical context has been so difficult. Now, my field is educational technology, and my field is unfortunately also dominated by no significant differences in the research. I used to be the editor of one of these journals. I've published in a lot of them. Every quarter, these journals come out and they're chock full of research studies, and unfortunately, many of them show very weak or no significant differences. This is also true of medical education literature. There's a preference in these journals for experimental designs, and yet no significant differences tend to be the dominant finding. And so there continues to be a wall, a big wall, a strong wall between medical education research, which is this whole little enterprise on its own, and then medical education practice. How do we get that, what we do learn from the research, into the practice is another major challenge. Another problem is that we do too much research on things. Whenever the latest thing comes out, whether it's an iPad or 3D printing or games and simulations, wearable technologies, virtual reality, immersive learning are the hot topics today. You can predict that there are going to be studies comparing these new things with traditional instruction. And what do you think they're going to find? No significant differences, no educationally meaningful differences. And so we need to stop doing so much research on things and instead focus our research on problems. There are many problems in education at every level, and many of these problems exist within medical education. Inadequate higher order learning, poor learner motivation, the failure to engage our learners. I remember not long before the pandemic, I visited one of the most well-known medical schools in the USA, and I decided to just drop by some of the lecture halls, and I saw that they were only about 20% of the students were attending lectures. They're just not engaged by traditional instructional methods. Lack of intellectual curiosity, weak communication skills, insufficient time on task. These are the problems that we should be focusing our research agendas on, not the latest technology. And also we have to admit the dirty little secret that so much of our research is just simply to build up our CVs, our resumes. It's publish or perish is what drives so much of our research. We need to change the reward system in medical education. So I believe that action research and design research, design-based research are two paths to a more socially responsible approach to medical education research. And this is what I'm going to focus on primarily. Now, many of you are familiar with action research and probably conduct it yourselves. It's usually conducted by people within a specific organization, for example, a medical school. And it starts with setting a local goal, for example, maybe to improve attendance at anatomy lectures. And you do hopefully explore relevant theory, literature, and practice, identify research questions. In action research, it's very eclectic with respect to data collection, use lots of different methods, analysis and reporting. And ideally, it results in the taking of informed actions, some way of resolving the problem that the study started with. Although action research is less formal than other types of research, action research can yield scholarly publications. I was looking through the literature, and I found a number of action research studies. In the Tuning Journal, there was a study called Developing a Reflection Guiding Tool for Underperforming Medical Students, an action research project. In the Korean Journal of Medical Education, there was the Improving a Newly Adapted Teaching and Learning Approach, Collaborative Learning Cases Using Action Research. And I even found a study that was conducted in Turkey. It was published in the European Journal of Public Health, but it was actually originally presented at your conference a few years ago, but it was a project on medical education without discrimination that looked at homophobia within medical students. And it was also an action research study. Now, another path to more socially responsible research in medical education is design-based research. In close collaboration with practitioners, define an important pedagogical goal, providing, for example, providing experiential learning to medical students during the pandemic. So one of the hallmarks of design-based research that maybe distinguishes it from action research is that there's this close collaboration between researchers and practitioners, and it addresses an important pedagogical problem. Within DBR, you create a prototype learning environment informed by the best theory and practice. You emphasize content and pedagogy rather than technology alone. You give special attention to supporting human interactions. And you test, refine, and retest the learning environment until the outcomes are reached that you were seeking to find. And you refine theory simultaneously, usually in the form of design principles. So that's a simple overview of action research and design research, design-based research. In the literature, I found lots of studies using DBR. For example, in the Medical Teacher Journal, there was a study called Design and Evaluation of a Team-Based Interprofessional Practice Placement, a design-based research approach. In the Canadian Medical Education Journal, Developing a Dashboard to Meet the Needs of Residents and a Competency-Based Training Program, a design-based research project. And then some of my own work that I've done with Umit and others, a study in interactive learning environments, on the bus and online, instantiating an interactive learning environment through design-based research. So there are studies out there using DBR as well. Now, design-based research is one term. I prefer the term educational design research, but really they're the same thing. Different countries prefer different terms. In the Netherlands, my co-author Susan McKinney, they primarily use the term educational design research. And so we call their book, which is now in the second edition, Conducting Educational Design Research. It's been translated into other languages, but not Turkish. If anyone's interested, that would be lovely. So educational design research is not defined by its methods, but by its twofold goals. First, you want to identify a problem and develop a robust program, product, or policy that will address that problem. And at the same time, you seek usable knowledge theory, such as design principles. So it's twofold goals. We have a model in our book. It's not perfect by any means, but basically you go through multiple phases: analysis and exploration, design and construction, evaluation and reflection. And in the end, hopefully you have a mature intervention and new theoretical understanding. And you're paying attention to implementation and spread all along the way. This is our generic model. Let me illustrate how it might be used. So there was a study published in EDUCAUSE Review, an online journal, in 2015 called Paper or Tablet, Recall and Comprehension. And this was a doctoral dissertation that was done in the United States. In the study, what used a randomized controlled trial. It was done at a Coast Guard training facility for non-commissioned officers. And the design of the study was that 231 students were randomly assigned to either a digital tablet version of a paper, it was an 800-word leadership article, or a paper version. The treatment time was less than 10 minutes. That's all the time it took to read this 800-word article. And then they had outcome measures, assessments. There were 10 multiple choice items to measure recall accuracy and 2 short essay items to measure comprehension. So this is an experimental study, randomly assigned students to either reading a paper on a tablet device or reading it on paper. What do you think the study found? Of course, no significant differences. Why would they have expected there to be any difference? You're only reading something. It's 800 words. By the way, it wasn't even aligned with their course they were in. It was just a random article about leadership. Why would anyone think that this was going to yield any kind of meaningful finding? And yet our literature is full of these types of studies. So how would you do this study differently if you used an educational design research approach? Well, the first thing I'd want to know, what's the problem? Why is this Coast Guard Academy getting tablets in the first place? Why do they need these devices? Are they short on paper? What's the problem there? So we go through a phase of analysis and exploration to really understand what's the problem that's occurring within this educational program. Maybe the problem is with their course alignment. You know, with any type of course, there's 7 critical factors that need to be carefully aligned: your objectives, your content, your instructional design, your learner tasks, your faculty roles, your technology roles, and your assessments. If these aren't carefully aligned, if, for example, you have higher order robust learning objectives, and then you don't test at that level, you don't assess knowledge at that level, then there's going to be a major misalignment. If your pedagogy, say using authentic tasks, doesn't match the objectives and the assessments, then you're going to have a misalignment. So maybe that's the problem within this Coast Guard Academy. Then we want to, once we really understand the problem from the perspective of the people who own the problem, then we want to go into the design and construction phase of educational design research. Perhaps the idea of just putting the readings on the devices is not addressing any kind of meaningful learning problem. But imagine instead that they could use these devices for using some sort of interactive simulations to help these Coast Guard non-commissioned officers learn how to safely load and unload people at sea, refugees at sea, migrants at sea, then it could have, the technology could be meaningful and useful. But just putting readings on a tablet, why would you expect any difference? So after you've got your prototype solution, then you would go through the iterative stages of evaluation and reflection. And this is where our model kind of falls down a little bit, because it doesn't illustrate how you go through multiple cycles of evaluation and reflection. But ideally, in the end, you have a mature intervention, a successful solution to the problem, and enhanced theoretical understanding. Educational design research is driven by the desire to have impact on real world problems. We shouldn't even think about doing action research or design-based research unless we really want to have an impact on real world problems. For example, I worked with some folks at the Baylor College of Medicine in Texas. I've worked with them for several years. And they right away during the pandemic were struggling with, how do you provide medical students opportunities to develop hands-on skills when they are forced online during a pandemic? So this goes back to the spring of 2020. And so my colleagues there decided to develop a new course that would enable students to actually develop solutions to this problem of how do you provide hands-on learning when you're forced online. The learning theories that we're exploring were experiential learning theory and authentic task design principles. And so they developed a new course at the Baylor College of Medicine about resilience through COVID-19, solving wicked problems. So what they did, the students in the course were split up into groups, and each team of students had a physician assigned to their team, and together they spent weeks coming up with new, basically plans for new ways of providing hands-on instruction online. And at the end of the course, each team had to present their solution, their proposals, to a professional group of judges, and the prizes were given. So it was motivating, but the whole entire course was conducted online at the height of the pandemic, when we were still very uncertain about how we'd even begin to deal with the pandemic and providing hands-on learning. And it was pretty successful. I'm really happy for my colleagues at Baylor. This was a quote from one of the students. She said, "I enjoyed working with my peers to address the task of creating a virtual platform for gross anatomy lab. I felt like my group came up with a product that could be used to improve the experience of socially distanced education." And the overwhelming results were very positive. Let me give you another example. This one comes from Turkey. You see here Umit, and Jim Vesper is next to Umit. Jim was had worked for the World Health Organization for quite some time, but he had his own company in the USA. And he once said to me, "Tom, I'd love to get a PhD, but I can't go back to school. I can't close down my company and go back to school." And I said, "No, you don't have to. We can do your PhD by research only." So he and I and a professor, Jan Harrington from Australia, we collaborated, and Jim conducted his doctoral dissertation research within the context of this project. And Hakan, to my right there, is another physician in Turkey, just a simply amazing person. So the problem was vaccine quality management, particularly the management of the cold chain for vaccines. And the way the World Health Organization had addressed this, the solution that they'd used for many years, was the bus course. And so once a year, they would bring 15 people from developing countries to Turkey. And because Turkey has such a great vaccination system, it was they would tour the system. I actually went on this course one time myself, and this is the route that it traveled the time I went. And it went from Izmir to Antalya, and along the way, the learners, again, who are all medical and vaccine professionals, so they're physicians, they're public health inspectors, pharmacists, etc. They visited a warehouse, a university hospital, provincial vaccine stores, family health centers, and finally retail pharmacies and so forth. So it was hands-on experiential learning in Turkey. Now, when I first met Umit in New Orleans at a conference, he gave a wonderful presentation about that course, and I kind of casually mentioned to him, you know, gosh, it would be great to put that course online. And so we decided to tackle the problem of how do you fit a bus into a computer screen? And I had given Umit a copy of one of my books, A Guide to Authentic E-Learning, that I wrote with Jan Harrington and Ron Oliver. And the next time I saw him, the book was so well read. He had every other page highlighted and lots of sticky notes in it. He really took it to heart. And he was very interested in the theoretical model that's presented in the book, which is basically 9 authentic learning design principles. We don't have time to go through these right now, but we decided to, Jim decided to do his dissertation using educational design research. So we went through the various phases. During the analysis and exploration phase, we met in various places around the world. This was in Georgia, but our team met and we began to figure out, okay, how could we take the experiential learning that takes place on a bus and put it into an online environment? Eventually, we got to the design and construction phase, and this was actually a meeting in Turkey where this picture was taken. But we began to design and construct a prototype e-learning environment to address the problem of putting the bus course online. And eventually, we got through the design and then got into the stages of evaluation and reflection. And this is where Jim collected most of the data for his doctoral dissertation. For example, you see at the bottom 2 versions of the course main screen. The initial version was very cartoonish, and after that was shown to various medical practitioners, they said, that's too silly, we need something more, more obvious and clear. And so the eventual course looked like the screen on the right. And there again, you see, it might be hard to see for you, but you can see they visited many of the same places they would have visited on the bus. And so finally, we went through the whole process and ended up with a e-learning, e-pharmaceutical cold chain management course that was first introduced in 2013. And it was a success for sure. And since this design has been applied to other courses for the WHO. And also out of the course came a number of design principles. Jim identified 9 design principles. This is just one of them. The fidelity of authentic e-learning must be sufficient to allow learners to suspend disbelief and feel that what they're experiencing is real. And we found that. The learners said, this is, like being there. These videos were produced in various warehouses and other facilities in Turkey, and you could just zero in down to an individual vial of vaccine. So in the end, Jim got his PhD at Murdoch University in Australia. I wasn't able to go over for that graduation, but there he is with Jan Harrington. In fact, he went on to win the Dissertation of the Year award from the Association for Talent Development in the US. And they flew him out to a conference in Denver, Colorado, and gave him a cash prize. And the course itself has won prizes. That you see Umit here with one of the prizes the course itself has developed, has won over the years. So I hope I've convinced you that educational design research enables a balance between the relevance and rigor of research that is socially responsible. That's really what it's all about. I think for decades, arguably, we've overemphasized rigor and underemphasized relevance. Our research needs to be both rigorous and relevant. And arguably, educational design research, design-based research, action research, all of these can be very rigorous, but they can also be relevant. So don't waste your life. Do educational design research. Now, I've finished a little sooner than I thought. I actually cut out about 20 slides last night. So we've got time for questions and discussion. Thank you very much.
Thank you, Dr. Luis. Yes, I'll give the floor to the attendants if there is any question. Yes, please, Dr. Armancı.
Thank you, Dr. Luis. Will you hear me?
Yes, I can.
Okay, thank you very much. Very, very enlightening talk. I want to tell you that I am a friend of UMIT's, and in fact, I'm one of the creators of the bus tour, the bus training project. We did the first ones together, the first couple of months. Then I joined WHO and left them in another process. But it's very good to see that it has really moved on. My question to you is, how can we make medical education ready to respond to real world questions that requires medical education to be in where people are being treated, being diagnosed, or where people are living, playing. So in other words, how do we make medical educators go into the field to see and experience the real world problems? Because I think that's where the curiosity will start. And as much as they move away from just publishing because of publishing and try to, focus in on the real world problems, I think that is going to be one of the necessities of moving into other types of research. And that's where maybe, we can be more ready and accepting to other types of research. Thank you.
Thank you.
Yes, thank you for your question. I assume everybody there could hear that question. And of course, it is a wicked problem you're describing for sure. Most of my career, in fact, I was at the University of Georgia in the College of Education for 39 years, and I never became a dean or even a department chair. I'm not organized enough for that type of role. But if I had become a dean, one of the things I would have done is I would have insisted that the faculty spend half their time in the local schools, and that teachers from the local schools come in and spend half their time in the role of faculty. And in fact, I saw that done at the University of Missouri a number of years ago. And so they called everyone in the college was called a professional practitioner. And it was regardless of whether they were faculty for the University of Missouri or teachers in the local school system. They were all professional practitioners. And students often didn't know who they were dealing with. Are they dealing with a school teacher or a faculty member? It was really quite innovative. Unfortunately, it didn't last longer than the funding lasted for it, but that's the case with so many innovations. So I wonder if maybe a medical school could begin to have more and more of their faculty spend time in the community, and then have practitioners from the communities come in and play in roles within the college itself, school itself. So there would be more of a collaborative environment across the board. Now, that maybe is too grand a scale. So I also think that if we start our research with a significant problem and then involve all the practitioners. For example, I live now in Rome, Georgia, in a very conservative part of the state. And the vaccine rate in this state for COVID, in this part of the state for COVID is one of the lowest parts of the state. And so if I had a medical college here in Rome, they don't, but if I had one, I'd want to, or maybe a public health college, I'd want to say, you know, why is there so low a participation in vaccines here? What do we need to do? Let's tackle that. And so that could become the focus of our educational design research project. So starting with real world problems, I think, is another way of approaching that. When I was at my first job, when I finished my PhD in 1979, I went to Peru for a year as a Fulbright. When I came back, I joined the faculty at the Medical University of South Carolina, and I only stayed there 15 months. I was really distressed by, there were some wonderful people there, needless to say, but there was people just weren't engaged. So many of the faculty were involved in other things and ranging from their own medical practices to running antique stores and bed and breakfasts and so forth. They just weren't engaged. And there again, Charleston, South Carolina is one of the poorest parts of our country. And they weren't involved in the problems of the people where their school was located. So I'd like to see more of that type of thing.
Thank you, Dr. Revis. We need to close the community. Thank you. Dr. Durak.
Okay, thank you very much. I liked your presentation and the conception regarding learning domains and so on. But I have two questions. The first one is the quantitative domain. The last part, let's say at the end of quantitative domain, you said that doing, that's very important. It's linked with the engagement, acting, willingness, and so on. My question, the first one is how we can change medical educationalists doing educational design research. The first thing, is that teachable? Is that learnable thing? And can we consider this question as an educational research question? Is it clear?
I'm sorry, I didn't hear the last part of the
question. Last part is how we can teach educational design research to medical educationalists. Can we consider this as a question of educational design research question?
Yes. Yeah, that's a wonderful question. Thank you. I've actually been involved in a project with some physician colleagues in Boulder, Colorado, and in London, and we've been conceptualizing a different type of medical school. And in this medical school, it would only prepare people for primary care in developing countries. And we're still at the exploratory stage, but what I would like to see is that the students would come to a facility, we're exploring London as the location right now, from developing countries all over the world, and they would come there and spend 9 months, and during that time, they would be involved in courses and so forth, but they would also be design-based researchers. They would actually study their own education. They would be involved in research with the faculty. And so the medical education itself would be the subject of ongoing design-based research. And then they would go back to their countries for 6 months and apply what they'd learned so far, and then come back. And we don't know about what the different time periods would be, but over a period of years, they would be going back and forth from the research environment of the medical school itself and using EDR methods within their local communities to deal with health problems at the local level. And so that they would become not just practitioners, but researchers at the same time. Now that's a pipe dream at this point because it's, and particularly during the pandemic, we haven't been able to make a lot of progress. I can send you a website that describes the some of the ideas about that. In fact, I'm going to send you, the organizer of the conference, a number of links and articles and things that, and these slides as well. Please feel free to use them. But I would love to see medical schools have students involved in studying their own teaching and learning environments. For example, to start off their first semester by exploring the different learning domains, the differences between the cognitive, the affective, the psychomotor, and the cognitive. The cognitive domain is so critical in all fields, but particularly in medical fields.
Thank you. Any question? Yes, I understand we need a framework, research framework to involve our doctoral or other young researcher into the DVR. Thank you, Dr. Rees. It was very, very inspiring presentation. Thank you for joining us.
Well, thank you. And I wish you all well, and please stay in touch.
Yes, thank you. You couldn't see the hall, but there is a young researcher and there is some researcher from the WHO and some of the medical education from the Turkey.
Oh, okay.
Thank
Wonderful.
you.
Thank you.
Thank you. Bye.
Bye-bye.